Good evening. I'm Dr. Ted Denson from Cincinnati Children's, and welcome to our live event, My Future with IBD. I'm the director of our IBD Center at Cincinnati Children's, where I take care of patients with IBD and also do research. Our research program is looking at the causes of IBD as well as trying to discover new treatments.
I'm Chelly Dykes. I'm one of the GI doctors at Cincinnati Children's. I have a special interest in IBD. I'm the director of quality improvement within the GI division, and I have a special interest in how to use our information better to improve care for patients with chronic GI conditions like IBD. In particular, I have a special interest in using technology and telehealth to try and improve communication between patients and physicians and try and improve the care between visits to make outcomes better for patients with IBD.
So we're hosting tonight's event because we've been hearing that families are interested in learning about what's new in treatment and care for IBD. At Cincinnati Children's, we try to cover the full spectrum of activities that will improve outcomes for patients with IBD. We do research looking at the causes, clinical trials to discover new therapies, as well as the quality improvement work to make the most with what we have right now. Tonight, Dr. Dykes and I are going to be fielding questions together and answer as many as we can. We'll answer your questions as best as possible, but we can't provide any specific patient recommendations. Feel free to please start sending questions in and we'll get them queued up to answer. Please enter each question only once. If we can't get to it tonight, we'll send a follow-up email with answers to all of your questions in the next couple of days. So our first question for tonight is, what new medications and treatments are available? Fortunately, there are many new things that are available, and it's been remarkable the amount of progress since I first entered our field about 20 years ago now. The main class of new medications that are available are the medications called biologics, which we've had since the late 90s. And there's some new ones that are available, such as Entivio, and coming up soon, Stelara, which will give us great options for patients who don't do well with the ones that we've had for a while. There's also a lot of interest in new treatments beyond medication, specifically different types of diets or dietary supplements that might be helpful, and I'm sure we'll talk more about that tonight.
Our next question is asking about discussion of growth problems in children with Crohn's. Growth can be a problem for patients with both Crohn's and ulcerative colitis, but often in patients with Crohn's, this may be one of the first things that we see when we meet a young pediatric patient. For patients with growth delays, our goal of our treatment is to try and preserve normal growth, normal puberty, and normal bone strength as much as possible. And often that's done with a few things. Number one, we want to try and reduce or eliminate the need for steroids as much as possible, because that has been shown to be associated with worse problems with growth. And the next is to try and choose a medication that has the best potential to recover growth, to achieve remission, meaning clinically feeling better, but also to heal the inside of the intestinal lining. So for many patients with Crohn's and growth failure, one of our best medication groups are these biologic medicines that Dr. Denson was just mentioning, and that's often one of our approaches for patients with more severe growth failure.
So the next question we have is, can you address treatment of a young child whose symptoms are not just GI but include joint pain and malaise or feeling tired? And unfortunately, this can be pretty common both for young children or older children or teenagers, particularly with Crohn's, that as well as having the GI problems, they can have problems with their joints hurting and feeling tired. Usually if that's going on, it's because we're just not controlling the inflammation from the Crohn's or ulcerative colitis well enough. And so we'll look carefully with tests that we can do, either blood tests or x-rays or sometimes endoscopies, to see whether there's still inflammation. and then usually discuss adding additional medical therapies or different therapies to get the inflammation under better control. Sometimes we look at that and that all seems okay, and there are other things we need to do for the joint symptoms like physical therapy, or the fatigue like looking at nutrition and vitamins that'll take care of it by kind of really looking at the whole picture.
Our next question is asking if gastroperesis happens often in children with Crohn's. Gastroperesis is a condition where your stomach doesn't empty well and empties a little slower than normal. Gastroperesis can happen as a result of several different GI conditions. So being chronically sick can lead to slow stomach emptying. Sometimes recent infections can make the stomach empty slower. So slow stomach emptying or gastroperesis isn't a common occurrence simply because of Crohn's, but can happen in the setting of any active GI irritation. So often we have to, like Dr. Denson was saying a minute ago, we want to try and get good control over the inflammation in the GI tract and try and restore things back to normal as much as possible. But sometimes the gastroperesis or slow stomach emptying needs treatment different from typical IBD therapy. The next question is from the same person related to, I think, the initial question asking about treatment of Crohn's in the nasal cavity. So Crohn's disease can affect anywhere from mouth to anus, and so in the back of the mouth and throat. There are a variety of treatments available for oral Crohn's. Topical treatments and biologic treatments are often the most common, but sometimes they may require a different approach combined with an oral surgeon or an oral facial specialist with the IBD team.
So our next question is, can surgery be done for a duodenal stricture? So the very first part of the small intestine where the stomach empties into the small intestine is called the duodenum. It's a short area that kind of turns on a tight edge as food empties out of the stomach. And sometimes the damage from Crohn's can lead to a stricture or a scar in that area that makes it too narrow and makes it hard to eat and cause symptoms. If it's a stricture that's not too tight, we can do a procedure with the endoscope to kind of open it up with a balloon, and that's oftentimes what we'll try first. If that doesn't work, then one of our surgeons may need to do an operation either to remove the part of the intestine that has the stricture or to just kind of open it up without removing any intestine. But it can sometimes be a difficult part of the intestine for our surgeons to work with. And if that's the case, they sometimes need to do a surgery to kind of bypass the stricture by bringing more normal intestine up to the stomach.
Our next question is asking about the likelihood of rejecting a second or third biologic after a patient has already failed one or more biologics. This has been, unfortunately, a common problem for a fair number of patients over the years. And years ago, we didn't always know why patients were failing biologics. We had to decide, did they respond and lose response, or did they never respond? And that's still our primary question, whether patients ever responded to the medication that we used, or did they start to respond and then lose response. Now that we have the ability to check drug levels for a lot of these biologic medicines, this is giving us opportunity to keep some of these medicines around longer, because now we know that patients can keep these medications in use longer if they keep a good drug level between infusions or between injections, depending on how the medication is given. Our goal is to keep that dose high enough so that when you get the next dose, your body doesn't fight it off. For some people, that can be achieved just with drug level testing, but in some patients, they need a second medication to keep their immune system from fighting off that medicine when they get the next dose. So we're still learning a lot about the combination of biologics with other medications to try and keep those biologics in use longer, and that's the focus of a lot of work that we're doing in our hospital and other centers to try and figure out how to keep those medications in use longer, especially for our pediatric patients who need to be able to use these medicines for a long time. So we can't always promise that we'll be able to keep the medication in use for a long time, but we're learning more about how to do that, and we're seeing some really good results with drug level testing and potentially with combination therapy.
Yeah, that's absolutely right. That's a key part of what we've been changing in our clinical practice over the last few years, and we are seeing these medications work for longer periods of time for most of our patients, which is really important. Our next question has to do with surgery. It asks, when do you make the decision to do surgery for fibrosis and strictures versus medical treatment for the terminal ileum? And is there one medical treatment you recommend over another for them? So this is kind of similar to a question we had a couple of minutes ago. The terminal ileum is the very end of the small intestine where it connects with the colon. And it's the most common part of the intestine where patients develop Crohn's. And unfortunately, in the past, before we had better medicines, most patients with Crohn's would eventually need a surgery because the inflammation would turn into a scar, which is what the fibrosis is, and then the stricture, kind of a blockage in the intestine there from the scar. With better medicines that we have these days and using them earlier on, we're able to prevent that in most patients. We just did a large study in children where we found the rates of this are fortunately much lower than they used to be. But nevertheless, sometimes we are faced with patients who've already gone on to develop the scars. And I think what we've learned is if we've tried that early medical treatment and despite that, unfortunately, this stricture is developed in a very short part of the terminal ileum. It's usually only a few inches. We can assess that with x-rays like MRIs. And in most cases, if it's gotten to the point where the scar is kind of fully formed and it's really blocking things up and patients are having a lot of pain, the best option will be for our surgeons to go ahead with removing that very short area, kind of reattaching the normal bowel on other sides, and then our medications are very effective to keep it from coming back. So that's how we tend to think that through. In general, if we're worried that a patient's at risk for that happening, we'll be more likely to start with those biologic therapies like the Remicade or Humira sooner to try to get really good control of the inflammation and prevent it from going on to the scar and the stricture.
Our next question is asking about how long we should wait before seeing results of Remicade or Infliximab infusions, and if that medicine doesn't work, what are some other options? So we are learning a lot about timing of response, but usually people are starting to respond within the first few weeks of starting Infliximab or Remicade, similar to the other biologic medicines. The time to response may be different for different patients and can depend on whether you're also on steroids or using enteral nutrition or other therapies to try and feel better faster. But usually within those first few weeks, people are starting to feel better. In our group, some of the quality improvement work that we're doing is trying to use patient response to tell us when we need to give some of the doses sooner. We have an idea about how often we need to give infusions, but sometimes patients need a second dose sooner, or they need a bigger dose the next time. And our standard protocols are there because that's the information that we have, but sometimes patients' bodies respond a little bit differently, and sometimes we have to increase the dose or the frequency that we're giving doses to try and see a better response. And in terms of what's next, we talked a little bit about this a minute ago, but our goal is to make sure we know why the medication is working or not working. And so if it's not working, is it because it's just not the right medicine, or is it not working because there isn't enough of it? So that's where good drug level testing and communication with the healthcare team about what's going on can help us to decide, is this the right medication? Can we use it better so that we don't have to change it if we don't need to? And if it's not working, then make a decision about other medications. And there are other treatments that you can discuss with your healthcare team if this is happening, so that you can decide if it's time to move on or if there's a way to make the medication work better for you.
And the next question is a great question, and it's kind of related to that one. It asks, can you explain why adding methotrexate to a Humira regimen helps the patient who's not well controlled on Humira alone? And would there be a different path you recommend in place of adding methotrexate, or is that standard best practice? So usually we'll start with the Humira medicine alone because it's often enough to control symptoms and get kids growing better. But probably in a good number, it's not enough on its own. So if a patient isn't responding as well as they should, the first thing we'll do, as Dr. Dykes had mentioned, we'll to check a level of the Humira and to check whether a patient's forming a reaction against the Humira, these antibodies against it. And if we find that the level is too low and it's because the patient is already making these antibodies or reaction against it, adding the methotrexate can make those antibodies go away and make the Humira levels get to the level where they need to be to actually completely control the Crohn's. Other times what we find is that there's plenty of Humira, but that medicine on its own is just not working well enough. And fortunately, the methotrexate itself has some anti-inflammatory effects that will help treat the Crohn's. And so if we combine the methotrexate with the Humira, we get a better effect. And these days, I would say that's really kind of the standard as far as what we call combination therapy, combining both a biologic like Remicade or Humira with what we call an immune modulator like methotrexate. But going forward, we'll actually be participating in a study to really see whether that's the absolute best way to go.
Our next question is, I'm just going to summarize the question just a little bit, is asking about types of surgical options available for patients depending on the location of the stricture, and going back to the duodenal stricture question. So the duodenum is a very tricky area because of all the different things that can flow into it from the liver, from the pancreas. And so whenever you're considering a surgery, you have to know that you're in the hands of an experienced surgeon and that you're comfortable with what's happening. So I can't answer specifics about what particular options are available in one part of the small intestine, but it's something that would probably be best discussed with an experienced surgeon and the whole healthcare team, and preferably a team that's used to IBD-related complications, so that because of all the nuances that can go into Crohn's and the development of problems down the line, that we're not putting a patient at risk for more problems related to the type of surgery performed. So I can't give a specific recommendation about what type of surgery would be done, but the best advice would be to consult with an experienced surgeon and surgical center. And
so this is a really good question also. How do you measure if medications like Entivio are working if you don't have a way to test for levels or antibodies? So that's a really good question. As Dr. Dykes has mentioned, our most common biologic medicines that we use at this point, Remicade and Humira, we really rely heavily on being able to check levels and check for antibodies. Entivio is one of the newer medicines that's available that works in a different way. And so if Remicade or Humira aren't working well, it can be a great option to go to. Fortunately, we've actually just learned in the past week or two that there will be a test available where we'll be able to measure for levels of the Entivio also, as well as some of the other medicines that we use where we haven't had that ability before. So I think even in the next couple weeks, we'll be able to start checking those levels for the other newer medicines that we're using.
We're very excited about that. So
yes, yeah.
Yeah, so that's going to be a great thing for patients on these other medications. Our next question is about how often we use enteral nutrition, and if you don't know what that is, that's a liquid diet primarily, particularly for patients with Crohn's disease, or parental nutrition, which is liquid nutrition through the veins for pediatric patients, and what sorts of results we've seen how useful it is for remission and how useful it is for maintaining remission. So we do use these treatments a fair amount. We offer enteral nutrition for our patients with Crohn's disease. Unfortunately, it's not as helpful for ulcerative colitis. And it is as effective as steroids at inducing remission or making people feel better. We offer it to a lot of our pediatric patients. Not everybody wants it simply because of when you do this diet, you can't eat a whole lot of other food. And so some patients choose not to do that, but for many patients it can be very helpful. We did it ourselves for about a week just to see what it was like, and I think most of us would recommend it for many of our patients. The IV nutrition or TPN nutrition we do use for some patients. We thankfully don't have to use it a lot. In adult medicine, often they use it for people who have lost large segments of bowel and can't maintain nutrition by mouth. But we do use it in pediatric patients who need prolonged periods of rest of their GI tract or who can't maintain growth or nutrition by mouth alone. And in our group, we've seen really good results from growth and nutrition, and we have very few patients who are considered in failure from a nutritional status. We do have some patients who use the enteral nutrition to maintain remission, and in the literature it seems to be effective, and we're always happy to offer that to patients with Crohn's.
And I agree, and probably a key part of it is as our patients start to eat regular food again, to work with our dietitians and really identify which foods are going to be more likely to make their symptoms flare up again and which foods they'll do well with. But it can be a really, really effective way to get things to heal and then kind of move forward from there. But it does take a lot of motivation to do it. So our next question is about a different type of therapy that's more experimental at this point. It's asking, is stem cell transplant a way to put Crohn's into remission? And so stem cells are kind of cells that they're in the body, they're in the blood and also in the bone marrow, which can heal parts of the body that are damaged and produce new white cells and blood cells. And so there's a couple types of stem cell transplants that have been tried for Crohn's. And the idea behind the first type was that since Crohn's is caused by overactive white cells, maybe you could use very strong medications to get rid of those white cells and then replace with stem cells that would become new white cells and hopefully not cause Crohn's. And that's called a hematopoietic stem cell transplant, or using cells that will turn into new white cells. And so that's been tested pretty extensively in adults, mainly in programs in Chicago and Seattle. And while it was found that initially patients would go into remission and get healing in the intestine, unfortunately for most patients, eventually the new stem cells turned into the kind of white cells that would cause Crohn's again. So that sort of stem cell transplant is still certainly something that's more experimental in adults in clinical trials. Another variation of that is something called a mesenchymal stem cell transplant. Mesenchymal stem cells are stem cells that can come from the intestine or from fat, from adipose tissue, and can actually just be given into the blood and will kind of home to damaged parts of the body like the intestine and heal it. And to do that sort of transplant, you don't need to kind of give chemotherapy or get rid of the white cells that are actually already present. So it may wind up being a safer type of stem cell transplant that can be used to heal the intestine in IBD. And that's something that's also ongoing in active clinical trials, mainly in adult patients at this point, but which I think will be very promising in the future. We have our biologic therapies, and then we'll be moving into different types of therapies or additional types in the future. And one of them probably will be different types of what are called cellular or stem cell therapies.
Our next question is asking about future studies that might show us whether a specific diet called the specific carbohydrate diet will be for the treatment of Crohn's disease. There is a study currently enrolling for adults for specific carbohydrate diet, and there have been some smaller studies for pediatrics looking at specific carbohydrate diet, and patients in general, in the smaller studies that we've seen so far, do seem to feel better on specific carbohydrate diet, which is basically takes out certain types of carbohydrates or sugars that are thought to cause inflammation in the GI tract. We haven't, as a society, seen enough evidence that we routinely recommend this for all of our patients with IBD, specifically Crohn's disease, but we're always interested in learning more. So one of the ways that in our group that we've used this is one of the telehealth interventions that I was talking about in the beginning is a way that we can do what we call N of 1 trials, where we can monitor a specific patient on a treatment already and then use a secondary treatment like specific carbohydrate diet to monitor their symptoms and monitor their response. For now, that's the way that we've done it in our group. We are trying to learn more as a group, and hopefully we'll be part of other studies for pediatrics in the near future, looking at the effectiveness of this diet. The specific carbohydrate diet can be a little bit limiting for pediatric patients, and so sometimes we have to just pay special attention that patients who are already at risk for growth problems are getting adequate nutrients to grow and develop. So we're learning more. There are studies underway, and hopefully will be more for pediatrics in the future, because this is a very hot topic right now, using different diets for treatment of Crohn's and ulcerative colitis.
Yeah, I agree. I think it's something that a lot of patients, particularly adult patients, have tried for years, and there's kind of a resurgence of interest in studying these in adults and kids in kind of a formal way to see what they really do. So the next question is, are there any progress with fecal transplants? So we know that changes in the bacteria, which are called the microbiome in the intestine, are common in patients with Crohn's or ulcerative colitis. And we know from studies that have been done in the laboratory that you absolutely need those changes in the microbiome to trigger inflammation in the GI tract. And so there have been many different ways that have been looked at to try to change the bacteria or microbiome back to a healthier mix. There's a particular type of infection called a C. diff infection, which can happen in anyone after you've been on antibiotics and can be a really miserable infection to have. And it's been found that doing a fecal transplant can be very effective to suppress the C. diff bacteria and kind of restore normal bacteria in the colon and kind of break that cycle. And the idea with this is that a healthy individual, oftentimes a family member, although some larger programs have actually banks of stool material that can be used for this now, provides a stool sample, it gets screened for any infections, and then it's kind of prepared and then can be given either as an enema or through a colonoscope during a colonoscopy. And the idea is that the bacteria that are kind of coming from the healthy individual that doesn't have C. diff or doesn't have Crohn's or colitis may create a more healthier mix in the intestine. So it's very, very promising for these C. diff infections, particularly if you don't have Crohn's or ulcerative colitis, and has really become almost the standard if antibiotics alone don't get rid of the C. diff. If you have Crohn's or ulcerative colitis, it's a lot less clear. There have been, unfortunately, some patients who've received the fecal transplants and they've actually triggered flares, because it's a little bit unpredictable what effect they're going to have if you already have IBD. In the largest study that was done so far in Canada, where they looked at adults with ulcerative colitis, there were more adults with ulcerative colitis who went into remission with a fecal transplant than patients with ulcerative colitis who did not receive the transplant. And kind of the key thing the investigators found was there was actually one donor who accounted for almost everyone who got better. So they're going back and looking at that information now and keeping track of that donor and really trying to understand what was special about that individual that was beneficial when the stool from most of the other donors wasn't helpful. So more to come on this, and I think they're also going to be, I've heard, kind of pills that essentially will do the same thing, and probably not too distant future, as another way to kind of get back to healthier bacteria in the intestine.
Our next question is asking about any current research being done with low-dose naltrexone for Crohn's disease. I'm not aware of any current studies. Dr. Denson may know more, but I haven't heard about any recent studies looking at low-dose naltrexone. There's been some work in the past in small numbers, not shown to be terribly efficacious or useful, but was certainly interesting and hopeful. But I haven't heard about any new studies, unless you know something that I know.
No, I think that's right. There were a couple of promising smaller studies several years ago, but it's not an area that's really actively being looked at now that I'm aware of.
Okay.
So have we heard about research with MAP, or Mycobacterium avium paratuberculosis? I believe Pharma is currently performing a study, and then there's a study number that's given. Along that lines, there's a great website that's available called clinicaltrials.gov, and all the studies that are being done for IBD treatment in the world are on that website. They have to be registered there. And you can kind of cross-index where you live, like Ohio, whether you have Crohn's, and find out right away all the clinical trials that are enrolling with new therapies. So I think this is probably referring to the study number for that study on clinicaltrials.gov. So the idea behind this is that Mycobacterium avium paratuberculosis, or MAP, is a kind of slow-growing bacteria called a mycobacteria, which causes a disease in cattle, Jones disease, which seems very similar to Crohn's. And in some studies over the years, including recently, some patients with Crohn's have been found to have low levels of this mycobacteria in the intestine. So there's been a question about whether in some patients this could be contributing to their disease. There was a large study of antibiotics that was conducted in Australia several years ago, which would suppress this mycobacteria, and unfortunately overall didn't show an effect as far as being beneficial for the patients with Crohn's that were in the study. One challenge that there's been is that it's very difficult to detect this and to really know for sure whether it's contributing to an individual patient's disease. But there are studies that are still ongoing, I think both in terms of potentially vaccines against MAP or other treatments for MAP. So more to come on that, and can certainly look on clinicaltrials.gov to see what's actually enrolling.
Our next question is asking about the likelihood of a middle child developing IBD or Crohn's if older and younger siblings have Crohn's or IBD, where parents do not have IBD. So IBD is a condition that has a genetic component. There have been hundreds of genes identified that have been shown to contribute to the development of Crohn's and ulcerative colitis. But there are other things that make people get it, and unfortunately we don't know what all of those are. So some of those things may be previous infections, or certain bacteria that live in the GI tract, maybe something about our diet in the Western world in particular that makes us more at risk to get it. And in families without a history of IBD, we see new patients with IBD, and certainly in families that both parents have IBD, we do see more children have IBD, but we can never predict with 100% certainty who's going to get it and who's not. So we can tell that there's likely a genetic risk, but we don't have a way to genetically test to tell who's going to get it and who's not. So clearly there is a genetic risk there if there are more than one kid in the family that have IBD, but we can never exactly say what the risk is for the other siblings. So we're learning more, in monitoring through a lot of the patients in our studies, and we in our center have studies looking at siblings and other family members trying to figure out what some of those associations are, but we can't always predict who's going to get IBD.
Yeah, and sometimes I get asked, is there anything we can do to try to reduce that risk? And the advice we can give is probably what all of us should do, to eat a healthy diet without a lot of the kind of saturated fats and simple sugars that may be a little bit more inflammatory. And to really talk to your doctor if they're prescribing an antibiotic, and maybe not go on an antibiotic every time you're sick unless you really need it. Because as far as we can tell from the research, it's probably these changes in the microbiome or bacteria that are the final step that may bring out Crohn's or ulcerative colitis in someone, and probably sticking with what would just be viewed as a healthier diet and less use of antibiotics if possible are the two things that you might be able to do to reduce that risk while we're still learning more.
Our next question is asking about what we would consider after a patient has failed all biologics, even if they had severe reactions to the medicine, like a severe allergic reaction, so that we're concerned they can't go back on those medicines. Is surgery the only next option? The answer to this question is a little bit tricky, and it depends a little bit in part on the type of diagnosis. So if you have somebody who has failed multiple biologics and they're sick still and has ulcerative colitis, then surgery would probably be a good option, because surgery is ultimately curative for ulcerative colitis. For Crohn's disease, it's a little bit different, and so our goal usually is to preserve as much intestine as possible. So there are some surgeries that can be performed for patients with severe Crohn's disease who have not responded to traditional therapies or who have failed biologics. But some of that depends on where the location of the disease is. So if a patient with Crohn's has disease in their colon, then sometimes they can have surgery to take the stream of intestinal contents away from the colon for a period of time, let the gut rest, and try something else, something like tacrolimus or nutritional therapy or methotrexate or other immunomodulators if they haven't used them before. But there are some other medications coming down the pipeline, things that haven't been quite approved yet, but there are some surgical options for both Crohn's and ulcerative colitis that can be discussed if a patient has failed multiple biologics. But there are some less common therapies that you could talk to your doctors about that may have some benefit for patients if they truly can't take some of those other medications.
So our next question is about any new developments related to prebiotics or probiotics or the prebiotic study that we're working on developing. So thank you for that question. This is something I'm actually really excited about right now. But for probiotics, probiotics are taking live bacteria, usually in a capsule, to kind of get at the same idea as the fecal transplant, to try to take enough of the live bacteria to restore kind of normal, healthy bacteria in the intestine and use that as a way to treat IBD. And there's a particular type of probiotic called VSL3, which has had the best evidence for ulcerative colitis, along with medications. These are always used along with medications, and we've known about that for a while. But there have also recently been some studies in Crohn's showing that it may be beneficial as well. So I think it's always worthwhile to talk to your GI about what probiotics are out there, and I think particularly if you have ulcerative colitis, the pros and cons of adding one to your regular medications. What's a little bit newer now is work that we're doing with something called prebiotics. And the idea with prebiotics is that they're kind of natural dietary ingredients that you eat every day, and then they just cause the healthy bacteria in the intestine to thrive more and kind of crowd out the unhealthy bacteria that are driving the Crohn's or colitis. There have been a couple of studies on prebiotics over the years, but actually not nearly as many as for the probiotics. And we're currently working on one called 2-fucosyl lactose, or 2FL, which is actually a sugar that's very common in breast milk. So there's sugars in breast milk that have something to do with why breastfed babies tend to have very healthy bacteria, something called bifidobacter, and may get fewer diseases like allergic diseases. And through research that's been done in the lab, both in Boston and here at Cincinnati Children's, we found that this one particular one, the 2FL, will really cause the healthy bacteria to thrive in the intestine. And in turn, those bacteria produce products that can kind of turn off inflammation and help the intestine heal. So we've been working with companies in Massachusetts and Holland so that they can produce enough of this 2FL that we can start to test it in patients with IBD. And hopefully we'll be getting to that by the end of this year. And what we'll be looking at will be different amounts that can be taken as a dietary supplement along with your regular anti-inflammatory medicines, but that maybe this will kind of shift the microbiome back towards healthier bacteria and help our patients stay under control long-term without the ups and downs that so many of them have. So more to come on that, but I think that's one of the most promising things that we're working on right now.
Our next question is asking about the usefulness of vitamin D and turmeric. So vitamin D in particular is very important to most of us that take care of patients with IBD for a variety of reasons. One is that our patients tend to get steroids from at least a diagnosis and may get steroids later, which can cause decreased bone strength and patients can have growth problems, as we discussed earlier. So giving supplemental vitamin D for patients who are deficient or patients who have low bone strength can often help recover bone density for those patients. But if you look up vitamin D in a scientific search engine, you'll find all kinds of stuff about what it does. So it's not just related to bone strength, but it also has some hormones type roles, and it may have some role in gut healing. And so from a quality improvement standpoint in our group several years ago, we found that patients, if we were able to improve vitamin D levels, we also improved outcomes. So patients with better vitamin D levels were more likely to be in remission and stay in remission. So for our group, we promote regular checking of vitamin D and try to keep patients above a certain threshold of vitamin D level. So that's one of the things from a quality improvement standpoint that we try to do to help maintain disease status in bones and growth as much as possible. Turmeric is basically a derivative of a spice that has been looked at in very small studies and seems to be similar to an aminosalicylator, an ASA type product. We don't have enough information about turmeric as a medication to say that it's useful or not. I have had several patients try it and do more of the N of 1 type approach with it. But we don't routinely recommend it for every patient for a couple of reasons. One, we don't know for sure that it's helpful or not. We also don't know enough about the types of supplements out there to know exactly what's in some of the supplements that you can buy. And I recently looked on just a common shopping service online that most people out there may know, but basically to see what's out there, and I found over 100 different types of turmeric with different doses and different strengths and different recommendations for how often to take it. And that's the tricky part about supplements like turmeric, is that they may be helpful, but we don't know how to dose it. We don't know if they're going to interact with other medications, and that part gets tricky because a lot of patients end up on a lot of other things. And so the herbal supplements may be good, but if you use them as a medicine, they're a medicine. And so we just have to be careful that we're giving what we know and how to use them safely, and that's not always there with turmeric and other similar herbals.
Yeah, I absolutely agree. And kind of the key thing, since there's a lot of interest in these, is just to talk to your doctor about whether you're interested in trying something and look and make sure there aren't any of those interactions or other things to worry about.
We have special ways of looking at it with our pharmacist and looking at different brands that might be more appropriate to try.
So the next question is about thoughts on early onset IBD and immunology, or those overactive white cells, or sometimes underactive. And is there any research for the under 5 IBD patients among multiple hospitals? So unfortunately, the most rapidly growing group of patients with IBD in North America and Europe are in children under 10. And there are good studies in both parts of the world that have shown that it's almost doubled over the past 10 to 20 years. And then in particular, it's starting to shift to really young children, children who are under 6, when they're first diagnosed, which we now call very early onset IBD. The average age when children are diagnosed is usually around 12, but that's starting to shift to even younger. There is a large multi-hospital international consortium called NEOPICS, NEOPICS, which is working together to understand what causes IBD in these children. And they have an ability that if you would like your child to be involved in the research, we can help with that. It usually involves a blood sample and some clinical information. What we tend to actually do in the clinic is that we've learned that if a child is very young when they're first diagnosed, they may actually have what we call a primary immune deficiency, or a problem with one gene in their body that's actually making their immune system too weak. And then the Crohn's or the colitis is kind of a symptom of that, but it's very different than Crohn's or colitis in older patients. And so we'll work with our immunologists at Cincinnati Children to sort that out. And I have, for example, had a couple of patients where that actually did lead to a stem cell transplant that was a cure for them, because they didn't have the same type of Crohn's or ulcerative colitis that older children and adults have, and can also lead to different types of therapies. So through our quality improvement and this large network, we do have kind of a different immune panel of tests that we send on any patients that we see that are under 6 to make sure something like that isn't going on that we would want to treat differently.
Do you want to answer the next
Yeah,
question, since it's kind of
the
related?
next question is a good follow-up to that. It's actually asking what's the actual incidence rate of under 5. I'm not sure what the actual incidence rate is as of now. The prevalence rate, or how many kids in the U.S. would be involved, is that there's about 100,000 kids who have IBD in the U.S. and over 1 million adults. And it's about the same in Canada and Europe now, and unfortunately growing in Asia, in Japan and China and India. And in that shift, with kids being diagnosed at a younger age, there are as many as 5% of patients are being diagnosed under the age of 6 now, amongst all the children that get diagnosed. So you can get to a few thousand kids in the U.S. who have Crohn's or colitis under 6. And unfortunately, probably because of these changes in the environment that we've been talking about, is continuing to grow. And then the other part is, how is the disease presentation different? Well, unfortunately, it tends to be more severe. It tends to usually involve the large intestine or the colon, and sometimes with very severe kind of bleeding and diarrhea, and difficulty with the babies or very young children being able to get in enough nutrition to grow. So we're a little bit more likely to need to use that parental nutrition or nutrition in the vein in the very youngest patients who have it, and sometimes come up with ways like feeding tubes to provide additional nutrition long term. So those are probably the two major ways that it's different. And of course, we worry if a child is 5 and they have this disease for their whole life, what are the effects of the treatments we use, and how do we balance that as well?
Our next question is shifting to our older patients and asking about how we help our pediatric patients transition to adult care independently so that they can manage their disease on their own. And this is a very important topic for all of us, and this is one of the things that we talk about at almost every national meeting we have, and we talk about with our own group basically every week. How can we help our pediatric patients become successful adults? And navigating the healthcare system is not easy, and so for us, our approach is to start early. So we start talking to patients about self-management and transition early, so around age 14. So the transition process is separate from the transfer process where you go to adult care. So for us, around age 14, we start asking questions at every visit about how comfortable patients are with different aspects of their health care. How comfortable are you with prescriptions and calling for refills and talking to your doctor? And early on, we expect that most patients are not going to be that comfortable with most of those things. But we identify something that's helpful for that patient that they're interested in and try and work on that over the next few months between that visit and the next, so that we pick something appropriate to that child and appropriate to their level of interest so that it's meaningful for them, and then build on that over time so that hopefully by the time they're a late teen, they're able to do more of those things on their own, so that by the time they go away to advanced training or into the workforce, that they can communicate with us, make sure that they understand their disease and how to do that. So we have a fairly structured process that is still always in development, trying to improve it, make it better, and make it appropriate for the patients. We involve our parent advisory group and our patients in that process to try and make sure it's as useful for them as it is for us. But we're fortunate to have a social worker who helps us as a transition coordinator, and she makes it easier for us. But this is an issue for the entire community of doctors who take care of patients with IBD, and so at our improvement collaborative meetings with centers across the country, this is something that multiple groups are looking at to try and make sure we do this in the best way possible. And I don't think any of us have it down perfect, but we're always trying to do it better and make things as smooth as possible during that transition to adult care.
Yeah, absolutely. So this is a really, really difficult problem sometimes, is what is your best suggestion for controlling pain? Especially since some narcotics can cause constipation as well as really significant problems. It's actually been shown that, particularly in the past, when narcotics were used a little bit more often for pain in patients with Crohn's, that patients with Crohn's who took narcotics always had worse outcomes than patients who did not take narcotics for pain. But the narcotics have lots of problems, but other meds are not strong enough to help. So there are several things that we do to try to address this. Fortunately, we do have very fortunately, we do have a multidisciplinary pain team that we can work with that includes both anesthesiologists who are experts in using non-narcotic medications for pain, and we do have several options as far as non-narcotic medications. Oftentimes, a significant thing that can be very effective is working with our psychologists or behavioral medicine doctors on relaxation techniques and kind of mind over matter, and where it almost seems like it's not possible, but just doing these things every day can significantly reduce the level of pain. Complementary approaches that can be done along with what we can do with relaxation and non-narcotic pain medications. And then we do look very hard to make sure there isn't something that we talked about earlier, something like a stricture or scar, which particularly if it's in the small intestine can sometimes be difficult to identify. We might have to use a video capsule or something like that to sort out whether the persistent pain is for some scarring that our standard medications might not be able to help with. But the key is really kind of that multidisciplinary team working together and understanding that we need to kind of be in this, all together for a while for it to come together and really work for the pain.
Our next question is how often we see IBD change from ulcerative colitis to Crohn's in pediatric patients. So this is something that, especially in younger patients, that we do see, and the difficulty is that in younger patients, like Dr. Denson was saying earlier, often their disease is in their colon, and for some very young patients, their disease looks like ulcerative colitis and acts like ulcerative colitis, but they actually have Crohn's. This matters most if you're considering surgery. So often if you have more severe disease, the medications that you're going to use are going to be similar, whether you have Crohn's or ulcerative colitis. So it matters the most if you're considering surgery. So not often, but a small percentage of time, we do see patients who we think have UC, and we go to surgery, and they might actually have Crohn's. They see this in adults as well, and in large centers that do large numbers of surgeries for ulcerative colitis, they still see this in adults as well, because our best available diagnostic tool right now is endoscopy, and you can only sample tiny little pieces of the bowel at any one part in time. We don't have a specific genetic test to tell us the difference. We're learning more about the bacterial differences between Crohn's and ulcerative colitis, but there aren't easy blood or stool or tissue tests that can always tell us. There are some features that can tell us easily that someone has Crohn's, but they're not always there. And if they're not, then sometimes we are left with making a decision about is this Crohn's or ulcerative colitis, and a very small percentage of the time a patient may be thought to have UC and actually has Crohn's.
Well, the next question, I might pass to Dr. Dykes, but it's a great question, but just not something that I know a whole lot about in terms of literature, although I know there are patients that seem to benefit for sure. It's asking, is there any research on acupuncture in Crohn's? And that's one of the kind of complementary things that I was kind of alluding to but didn't mention earlier that could be helpful for chronic pain or other symptoms associated with Crohn's. I haven't had any of my pediatric patients use this, but I think we have had some patients in our practice that have taken advantage of this locally.
I've had pediatric patients who have been treated with acupuncture for Crohn's, but more for nausea and pain. So there is evidence about the use of acupuncture for management of chronic symptoms like pain and nausea in the literature, and it is effective for a fair number of patients. Locally, we do have some providers who will use acupuncture on younger patients, and I've had very good results with the patients that I've used it for patients with chronic pain or chronic nausea as a result of their IBD. So in my personal experience, I've had a good experience with it, and I talk about it with my IBD patients. I also talk about it with my patients without IBD who have chronic abdominal pain, and many people do find results. As far as healing of the GI tract or improvement of inflammation, I don't know that I've seen any literature on that, but it has been used for symptom control. And I'll talk about it in patients as part of that multidisciplinary approach for pain and part of the integrated pain approach.
Okay, and our last question, which we'll probably both touch on, is do you think there will be a cure for IBD in the future, and how close is this? And of course, that's the goal in our research. Unfortunately, IBD, like other chronic illnesses like asthma or arthritis, will be difficult to have a cure that would completely get rid of it and not need any medication or dietary changes. Because unfortunately, kind of the susceptibility to trigger the inflammation will tend to be there. I think right now we have very, very effective anti-inflammatory medicines to get at one part of the puzzle. And what we're developing in the near future will be better, well-studied ways through things like the prebiotic I mentioned or diet to really change another major part of the puzzle, the microbiome or the bacteria. And I think if we can do that, we'll get a lot closer to our patients having a very stable course, not as many ups and downs. The third part of that will be needing to understand more about what is in our environment that's triggering these flares. And we have studies looking at that, and what advice can we give our patients about that? So I think that's what a cure would look like. Still our anti-inflammatory medicines, but better ways probably through diet and other supplements to change the bacteria and the microbiome in individual patients, so things are not as likely to kind of go up and down for them.
And from my standpoint, the work that I'm doing within the improvement side of things would be ways to communicate between visits, to eliminate those ups and downs, to know when those ups and downs are happening real time so that we can make changes then rather than waiting for a bad flare, and so that we can intervene sooner, make changes sooner, and not have those risks of complications down the line. And that's ultimately the goal of combining all of these techniques and research with clinical care and partnering the patients and the physicians together to try and take better advantage of technology and communication and try and really make those things work better for patients to get the best outcomes possible.
Well, thank you very much for joining us tonight. Unfortunately, we've kind of come to the end of when we can answer questions. Please call us if you'd like more information or to schedule an appointment, and we'll be sure to answer any questions we may have missed and email them out to you soon.